Right, sir.
Yeah.
Sure, sir. So I think, sir, we can start, sir. We have eminent
Okay.
Professor Dr. Anish Bhattacharya with us, who will take us for nuclear medicine and nephrology. So the session is all yours, sir.
Okay, thank you. And thank you for inviting me. I believe the audience is of the DNB students for nephrology.
Yes, sir.
So, yeah. Right. So, let me tell you in advance, please, I apologize for any discrepancies, or if I seem a little distracted, there's some medical problem going on at home. So one ear is out on the other side. I'll try to do my best under these circumstances. So this session is on the nuclear medicine applications in nephrology. Um, those institutes which have a nuclear medicine setup, this shouldn't be a very major issue because you're routinely using these investigations. For those who have less exposure, I try to cover all the routine practical aspects. So briefly, when you talk about the applications of radiation in medicine, there are two types. One is radiotherapy and one is nuclear medicine. Radiotherapy, you're all familiar with, where sealed sources like cobalt-60 or radium or cesium needles are used. Either you use Linacs for teletherapy, or you have brachytherapy with the radium needles and cobalt-60 sources. In nuclear medicine, we use unsealed radioactive sources, which means that the actual radioactive material is in the form of a liquid, solid, or gas, which can be administered to the patient. It's ingested, inhaled, injected, whatever. So these are used for both diagnosis and therapy, and as well as in biomedical research. So you have the gamma emitters, which are used for diagnosis, like technetium-99m, the beta emitters, which are used for therapy, that is like I-131 and lutetium-177. Iodine-131 is both a beta and a gamma emitter, so it can be used for both. And nowadays we're coming in with the alpha emitters, like actinium-225 and radium-223. So nuclear medicine essentially has three components. One is the physician, that's people like me, who do the reporting and who decide what investigation to do and how to do it. You have the radiopharmacist who prepares the radiopharmaceuticals, that is the radionuclides, which are bound to the chemicals or amino acids or molecules or cells or whatever to form the radiopharmaceutical, and the medical physicist who carries out the quality control of the instrumentation and takes care of the radiation exposure, the radiation dosimetry. Now, the radiopharmaceutical, I'll be talking about this in detail just now. So you have two parts. One is the radionuclide or the radioisotope, like technetium-99m or iodine-131 or iodine-123. That is the physical radioisotope which emits radiation. The chemical part, there will be lots of names. So when these two are tagged together, that's the job of the radiochemist. The chemical part of it, or the molecule or the amino acid, carries the radiopharmaceutical to the target where it's targeted to. The isotope emits the gamma rays or the beta rays, as the case may be. So if the gamma emitting isotopes are used, then you can use it for diagnosis. If the beta or alpha emitters are used, it's used for targeted radiation therapy. So how does radiology differ from nuclear medicine? In radiology, when you use X-rays or CTs, you have a radiation source which passes the X-rays through the patient, which form an image on the imaging instrument. This is a transmission image, which is essentially an anatomical image. Radiation dose from these investigations are usually much higher. And in nuclear medicine, as I said, you administered the radiation source, that is the isotope, into the patient, and then it emits these rays all around. So when you're talking imaging, then it's gamma radiation, which is coming out, which is caught on an imaging instrument, which is a gamma camera or a PET scanner. So these are emission images, which are essentially functional images with a much lower radiation dose. Nowadays in nuclear medicine, you have a combination of these, like in the SPECT CT or the PET CT, where you can have both the CT as well as the gamma source. So you have hybrid imaging where you have combined anatomical and functional imaging. So coming to the renal scintigraphy, so begin with the basics, the radiotracers. So you have two types. One is the dynamic images, one is the static images. The dynamic imaging is usually done with these commonly used radiotracers, that is technetium-99m DTPA, technetium-99m labeled EC, MAG3, or I-123 labeled OIH or orthohydrohippurate. Now, these are the essentially the main tracers that are used. There are hundreds of others which you don't need to go into. The full forms For your interest, you can remember the names. Acronyms. So static imaging is done with technetium-99m DMSA or technetium-99m labeled GHA. We'll talk about each of these in detail as we go along. So what is the difference between dynamic and static and what these are used for? So now coming to first the classification of these agents. Just for your information, you have glomerular agents like I-125 iothalamate, chromium labeled DDT or technetium-99m DTP. These the first two are less commonly used now. It's technetium-99m DTP, which you need to remember as the main glomerular agent that we use in day-to-day practice. Then you have the tubular agents, that OIH, MAC3 and DC. OIH is less commonly available because the I-123 label is not available in India. MAC3 and EC are the common ones used. MAC3 is an imported kit. EC is available from India itself. It's produced by the Bureau of Radioisotope Technology, that is our own BRC. And then you have the cortical agents like DMSA and GHA. So what are these uses for? So now remember that when the clearance is less than the GFR, you have net reabsorption of the tracer like glucose and urea. When the clearance is equal to the GFR, then you have no net reabsorption. So those are the agents like inulin and TTP, which are used for GFR measurement. And when the clearance is more than the GFR, this is commonly seen with the tubular agents like PIH. So that's just a representation of the nephron, showing you what happens. There's filtration from the blood plasma into the nephron in the capsule, tubular reabsorption in the from the filtrate to the blood, and tubular secretion from blood into the filtrate. So glomerular agents can therefore measure GFR better. This is used for example, in post-transplant patients. The extraction fraction is about 20%. Tubular agents, they cannot measure, but they have a much lower background activity and a higher kidney to background ratio because the extraction is much higher. Generally we use the tubular agents in early life, like in infancy, because the infant kidney is immature. So renal clearance is better with the tubular agents. Renal uptake of the tracer is particularly low in infants with a higher background activity. So preference in young children will be given to tracers with the higher extraction rate, that is the tubular agents like Hepuran, MAC3 or technetium EC, and not DTPA, unless you specifically want to measure GFR. So tubular agents, this I-123 and I-131 orthoiodohepurate and technetium MAC3 with the iodine labeled iodohepurates. The disadvantage is that if you're using I-131, then the imaging characteristics are poor and you have a higher radiation dose because, as I said, I-131 is a beta gamma emitter. There will be beta radiation also. I-123, the availability is limited. So you're left with technetium MAC3 and technetium EC. So these are protein-bound agents. The MAC3 especially is highly protein-bound. Extraction fraction is 40 to 50%. It is more than twice that of technetium DTPA. A small fraction will be excreted by the hepatability system, giving you visualization of the gallbladder or small bowel in the delayed images. This is also seen sometimes with technetium EC, but more seen with MAC3. If you have a patient with suspected obstruction or impaired renal function, MAC3 and DC are the preferred agents. The reason being that technetium DTP has a limitation beyond a creatinine of about 2. You will get more background and less of kidney activity. With technetium MAC3 and DC, you can use it with a creatinine of as high as 3.5 to 4 and still get some kind of a quality of an image. So coming to technetium-99m EC, or there are two isomers, that is LL and DD. We prefer the LL form. So technetium LLEC is what we are using routinely. These have LLEC has a higher clearance than that of MAC3, and this is available within our country, as I said, produced by the BRC itself. So when you compare the three, OIH, MAC3 and LLEC, you can see if you have availability of OIH, okay, you can use it. It's preferable. It has a very high clearance rate, good extraction, much higher extraction efficiency, all in all better characteristics. But since we don't have it, we have a choice between these two. So out of these, LLEC is definitely a better agent when it comes to extraction efficiency. It has a much lower plasma protein binding, and the clearance is also slightly higher than that of technetium MAC3. It's also cheaper. MAC3 comes for about 6,000 rupees a vial. EC comes for about 1,000 rupees a vial. So it's 1/6 of the cost. Cortical agents like DMSA preferably is used. Nowadays, there are very few people who use GHA. DMSA accumulates in the kidneys through the megalencytosis. There is parenchymal retention of DMSA. So neither GHA nor DMSA can be used for diuretic renography. You don't use these for obstruction. You use this for renal cortical scintigraphy to look at the cortical morphology. I'll come to these later with graphical representations. So when you talk about technetium DMSA, it's bound to plasma proteins, which prevents it from glomerular filtration. At 1 hour after injection, about 50% of the administered activity is retained in the proximal convoluted tubule cells, and maximum cortical uptake is at about 3 hours. So clinical applications, when you talk about the dynamic images, either DTPA, EC, whatever we are using. So these are used for estimation of relative renal function, drainage in case of obstructive uropathy when it is suspected, calculation of GFR by technetium DTP and DRPF by technetium EC, evaluation of renovascular hypertension, location of small ectopic kidneys, and evaluation of renal transplants. Let's look at these each one by one. So first, coming to the patient preparation. Now you have to ensure hydration. This is very, very important when you're doing a dynamic renal scintigraphy, or even when you're doing a static renal scintigraphy. Adequate hydration must be maintained, especially when you're using furosemide diuresis to prevent dehydration, especially in infants and young children. You can use intravenous. In fact, you have to use intravenous hydration if the patient is not compliant with oral intake of fluids. Dextrose in water is recommended. The goal is not volume replacement, but maximization of urine output. So ensure hydration. That is very, very important. Again, I'm saying no special diet. You don't need to keep the patient fasting. In fact, it is better not to advise the patient not to be fasting to avoid dehydration. If the patient has had an IV contrast agent, radiological contrast, iodinated contrast injected, like IVP or CECT, then you have to delay the scintigraphy by 1 to 2 weeks. For IVP, it is preferably 1 week. A contrast enhanced CT has been done, then delay the scintigraphy by about 2 weeks, because this iodinated contrast will interfere with the radioisotope scintigraphy. The other way is not true. If you do a radioisotope scintigraphy, you can do an iodinated contrast study the very next day. There's no problem with that. But the contrast agents will interfere with your isotope scintigraphic studies. Bladder catheterization are not always recommended, but a full bladder can result in increased intravesical pressure, resulting in delayed drainage from the renal pelvis. So especially in non-toilet trained children, there may be a need to void, so you'll have a premature interruption of the study, or if the child voids, you'll have urinary contamination, because after all, the tracer is coming out into the bladder, so you'll have a tracer all over the pelvic region. So in very young children, non-toilet trained children, we prefer to put on a diaper to prevent any accidents of nucleate contamination. In toilet trained children, always, and other adults, you empty the bladder before the acquisition of the dynamic images. Bladder has to be catheterized for certain indications, like when you have a vesicoureteric reflux, or you have a bladder outlet obstruction, like meatal stenosis or spinal injuries, neurogenic bladder. Ectopic kidney, if you have a very low-lying kidney close to the bladder, then you have to keep the bladder empty throughout the study. Otherwise, the bladder counts will interfere with the kidney visualization. And if there's a significant post-void residual urine. So the whole idea is that the bladder must remain empty during the study, right? So for technetium DTP and EC studies, well-hydrated patient, the patient is placed supine, normal kidneys in the posterior view, transplant kidney in the anterior view. The patient is placed supine with the detector, that is the gamma camera, placed below the palate. So whenever we do technetium DTP or EC scans, you're going to see the posterior projection. So left kidney will be left, right kidney will be right. When you're looking at transplant kidneys, you take an anterior view. The tracer is injected intravenously, as I said, 1 to 5 millicurie dose, depending on the size of the patient and body weight. We acquire immediate dynamic images for 25 minutes and delayed static images up to 5 or sometimes even up to 24 hours. Administered activity for adult patients, it is about 4 millicuries of technetium, EC or DTP or DMSA, whatever it is. In transplant kidneys, we double the dose because you need a better perfusion assessment in transplants. So you need a higher dose for the bolus. Pediatric doses are calculated by the Webster's rule given here, or you can use the E&M dosage card as is shown here to calculate doses from 1 year to 18 years. Furosemide usually given in the dose of 0.5 milligram per kg intravenous up to a maximum of 40 milligrams, which can be increased in case of compromised renal function. Now there are different furosemide protocols. You can give it as T-15, T0 or T+15. This is the time relative to the radiotracer injection. So T-15 or F-15, whatever you call it, is the diuretic is injected 15 minutes prior to the radiotracer injection. This is to ensure maximum diuresis during the actual, when the tracer actually goes in, the kidneys are under maximum diuretic effect. T0 or F0 protocol is used usually in children where the tracer is mixed up with the furosemide in the same syringe and injected at one go. This is to avoid giving a second tracer injection halfway through the study. The T+15 or T+10 is used where you inject the radiotracer first, let the study proceed as it is. If there is no obstruction and you see the starting off, there's no need for a furosemide injection. If you see there is hold up, then you can inject halfway through the study. But this involves the second injection. So in children, this can result in movement of the patient during the dynamic study, causing all kinds of problems when the image quality is concerned. Based on the requirement and convenience, you can choose one of these three protocols. So evaluation of renal function and drainage. Now this is a normal technetium EC scan. So you get all this information on the results page. You can also see these images individually on separate pages. Initially, for the first 1 minute, this is the flow phase or the perfusion phase, where you can see the tracer coming in through the abdominal aorta and then perfusing both the kidneys. So both the kidneys are well visualized, well perfused kidneys. You get a neat graph of that of the first 60 seconds. So sharp show perfusion and then it stabilizes. I'll come to this image just now. The rest of the 24-minute study is the cortical phase and the clearance phase. So again, you can see it's a very well-functioning set of kidneys. Both the kidney, renal cortex, cortices on either side show very good tracer uptake. Within the second to third minute, you start seeing tracer in the renal pelvis and it's appearing in the bladder. The ureters are briefly seen or sometimes even not even seen. So by say 7 or 8 minutes, the kidneys have almost excreted or whatever came in, bladder is full. This is, and the resulting renogram curve over 25 minutes. You can see this sharp rise, the rising phase of the renogram, a very quick peak within 2 to 3 minutes, followed by rapid clearance. So how is this renogram curve generated? You draw these regions of interest over the two kidneys and over the background. Some people prefer for the perfusion phase, you position a region of interest on ROI over the abdominal aorta. So these green and red regions of interest are what you see here also, green and red. And again, the two curves are superimposed one on top of the other because the two kidneys are identical in function, and then you get this whole lot of information out here in the results column. So this is being done with technetium EC, but we've used the MAC3 protocol because it's there is no software available for technetium EC with the customer vendors. So you get this, shows you the relative function. So roughly 50-50 on each side. You also get a whole lot of other parameters which may be used for specialized studies. So the renogram curve. Now, for some reason, everybody is fascinated with this renogram curve, and we keep getting these queries. What is the renogram curve? Please stop scribbling on the screen. It will be very difficult to continue. Whoever is scribbling, please delete these right now. Otherwise, it will interfere with the images later on. May I request the coordinator, please get these scribbles off the screen. Can whoever is scribbling on the screen, please remove the scribbles. It's interfering with the images. Okay, while you're removing the scribbles, I'll carry on with this particular slide. Please make sure that you remove the scribbles. So this is the normal renogram curve. So you have a concentrated initial vascular phase, a very sharp rise, and then the concentration phase with an early peak, and then a clearance phase. So from this part, you get the T half, which is usually 8 to 12 minutes. And you have different forms of the renogram curve. The left and the right are practically the same. The left is the colored version, the right is the black and white version. So the normal renogram curve is what you just saw here. And then you have the obstructive pattern where there is a rise and then it plateaus out or it continues to rise. Then you have the dilated unobstructed pattern where there is an initial rise and a plateau and then a rapid clearance. This is usually after the injection of furosemide. And the indeterminate curves where you have which you see report as partial obstruction, where the curve is neither coming down as in the A part, nor is it staying up as a plateau, but it kind of starts coming down. Now I'll just show you what we do with these. On the left side, these colored curves are the same. So the red curve shows a dilated high-grade obstruction. The yellow curve, now this is something you don't have on the right side. This is where you start seeing a delay, what we call as a depressed renal function. Now going on to the orange curve and the black curve, as the renal cortical function deteriorates, the curves will start becoming lower and lower till you reach the black curve, which is a practically low-lying flat curve. So there's a lot of information which you get from the renogram curve. The rate at which it rises up reflects the function. The rate at which it drops down reflects the drainage. If it peaks early, with technetium we see the peak is usually between 2 to 3 minutes. With DTP, it is between 3 to 5 minutes. So if it peaks early, you know that the function is good. If the curve starts moving to the right, now you have a hydronephrosis-like condition or a depressed renal cortical function. The more it moves to the right, that means the later the tracer is concentrating in the renal cortex. So which means depressed or an impaired cortical function. And the lower the peak, the less the cortical function, the less the contribution of the kidney. We'll show you these in the images. Now let's take a look at an obstructed hydronephrosis. Now here the left kidney, as I said, the left is left, right is right. So left kidney, normal cortical thickness, normal uptake. This is the splash page we call. This is the 24-minute study. Here it is 21 minutes actually. So the left kidney shows very good cortical uptake. You see the tracer coming out into the ureter 3 to 4 minutes into the study and then clearing out fast. The right kidney, on the other hand, this is a hydronephrotic kidney. So you have a thinned out cortex, a large photopenic defect in the pelvic ileal system. The kidney takes a lot of time to concentrate. Later on during the study, you see pooling of tracer in the PCS. And then we take these delayed images. Now, once you get this kind of a picture, what you're going to get is a plateauing or a flat line curve after an initial rise. We take delayed images, in this case up to 3 hours, which shows no reduction in the tracer activity in the kidney. This is a prolonged holdup of radiotracer in the PCS, which means it's an obstructed kidney. And the same thing you're seeing here in the renal renogram curves. Left kidney, that is the red curve, shows a normal renogram curve. The right kidney, which is the green curve, shows a rise with a plateauing. So next, a variation of this, you can have a renal cyst. Every photon deficient area is not hydronephrosis. So in the previous scan, what you've seen here is, there is an initial photopenic area corresponding to the medial part of this is the pelvic ileal system region, which fills up. This you can be pretty sure is the hydronephrotic kidney. When you look at this kidney now, it's not the medial, it's in the renal cortical region, the lateral part of the kidney. There is a sharply circumscribed photopenic defect, which remains photopenic throughout, even up to the delayed images. The rest of the kidney is drained off. So this is a renal cyst. This is not communicating with the renal drainage system. So this will remain as a persistent hold area throughout. This is a grossly hydronephrotic kidney. The left kidney again is normal cortical function, normal concentration, normal drainage. The right kidney is hugely dilated, very little functioning cortex seen. There is some concentration as you go along, but when you take the delayed images, it slowly fills up. So this is just one big bag of urine and there is no clearance. So this is a grossly hydronephrotic obstructed kidney. You can also have a duplex kidney. Now this is where you have a very interesting set of images. Left kidney again normal. The right kidney, initially you're seeing uptake only in the lower half of the kidney cortex. There's no uptake in the upper half. As you go along, the lower half started draining off. You can see it's collecting in the lower calyces and then the drains off, but the upper half starts to appear. Now, in the course of this 24-minute dynamic image, the upper half gradually fills in, and firstly take a left to right, take one ROI on the left side, one ROI on the right side. So the left ROI normal, the right ROI, which is being placed over the lower half of the kidney because the upper half is not showing any good function, is normal. So the lower moiety shows a good drainage, right? Okay. You can also draw two ROIs, one on the upper moiety, one on the lower moiety. Now, this program has only two regions of interest. So the red ROI has been placed over the upper moiety of the right duplex system, the green ROI over the lower moiety. So as you can see, the lower moiety has an excellent function. The percentage is about 72% in the lower half and 28% on the upper half. The upper half is a pretty flat line curve. It's not functioning very well. It shows a very sluggish uptake of tracer. What I'm trying to point out is you can quantify the relative contribution of each moiety of these renogram curves and the renal processing protocols. So you get not only the relative contribution of the left kidney and the right kidney, you get the contribution of the upper moiety and the lower moiety of the duplex system as well. Now, progressive follow-up of a kidney. Now let's see what happens here. This is a patient where the right kidney is doing fairly well. The left kidney is hydronephrotic. So the left kidney is the red ROI here. So the right kidney, the green curve, initially rising, holding up, and then when you're given furosemide, it drains off. The right moiety goes up. There's a brief plateauing kind of thing, then it stays up. And subsequently, this first study, I believe, was in 15th of January, 2020. The second study, sorry, just a minute, my mistake. This is to show the position of the ROIs. Now, this has to be done very carefully. Now, this is a patient where this is a hydronephrotic kidney, so this is a whole kidney ROI. Now, the positioning of the ROI can give a false impression of the cortical function. It usually gives a overestimation. Now, what you get here with the whole kidney ROI is, it says left kidney about 45%, right kidney 55%. If you exclude the dilated PCS and draw a cortical, pure cortical ROI, this is the actual function. It's 35% on the left and 65% on the right. This is a more realistic estimation of the cortical function because this is all the cortical contribution you have. Now, this is unfortunately a software problem which cannot really be taken care of unless you reposition the ROIs. Otherwise, you will get an overestimate out here. What will happen is when the surgeon operates to deflate this kidney, the kidney will shrink in size, and sometimes the post-operative may drop down below the pre-operative levels. So if we do use a whole kidney ROI like this, we can, what we do is we say 45%, but it is likely an overestimation. Okay, so this is a grossly hydronephrotic kidney again, right kidney, and it says that the percentage function is 30%. Now this is no way this is 30% function, it's a gross overestimation. This is the same kidney which I showed a couple of slides back. So follow-up. Now this is where the renal cortical imaging scores over IVP, scores over everything else because you can quantitate. Now this is a study where the left kidney is showing a normal function and normal drainage, the right kidney is hydronephrotic. The same thing, everyone is quite familiar with this now. This is on 23rd of September 2019. Renogram curves for the same kidney, the percentage function 55.56 on the left, 44 right. Look at the renogram curves. So the green curve, that is the right curve, is only partially coming down. This looks obstructed. The left kidney has an unobstructed drainage. First follow-up is on 21st of January 2020. Now you can see compared to the previous one, there is less uptake in the right kidney. And when you look at the renogram curves, it's significantly fallen down. The percentage function now going to 75 and 25. The second follow-up, no intervention has been done. 5th of June 2020, the right kidney is practically disappeared. Okay, hardly any function left. And the curve has gone dropped down to rock bottom. 95% function on the left side, 5% on the right side. For whatever reason, the patient was not intervened, and just the follow-up subsequently shows. So when you look at the renogram curves, you can say 56-44 in the first study, 75-25 in the second study, 95-5 in the third study. So serial imaging showing steady deterioration in the cortical function and to prove that it is going bad. Coming to GFR estimation. Now, the ideal tracer, there's a lot of requirements: low molecular weight, small molecular size, no protein binding, no cellular metabolism, no, should not interfere with the renal function, etc., etc., no nephrotoxicity, no net tubular secretion, no absorption. Inulin is the gold standard, but it's technically difficult to use and expensive, but it's time consuming to do the procedure. It requires multiple urine samples, and it's problematic in patients with urological disease, especially in children. So we use a convenient replacement, that is a technetium 99M DTP GFR estimation, which can be done either by the gamma camera or Gates method or a plasma clearance method. The plasma clearance method involves either a one sample, two sample, or multiple samples of blood collection. This is still cumbersome because it involves multiple samples to be collected of blood at timed intervals and requires trained staff and meticulous technique and some extra equipment. The gamma camera method is a simple procedure, no blood sampling is required. It's not very accurate, especially in children, but it is accurate if you're going to routinely follow up the patient on the same instrument. Now let's see what is done. To measure using the plasma clearance method, you give a bolus injection and you collect timed samples, as I said. So this is a multiple time sample. You have a bi-exponential clearance. So the area under the curve is used. Either you can use a bi-exponential or a single exponential method. There are many different methods to calculate. So we use a multisample method when a really accurate estimation is required. There's a complex formula for calculating. I'm not going into that because of lack of time. So what I'd like to point out is, the GFR that you get is about 90-95 ml per minute, and the normalized to body surface area will come to about 110 ml per 1.73 meters squares in a normal, let's say this is, I think, a renal donor estimation. Now, when you use a gamma camera method, you just have to do the routine DTP renal estimation, and you don't need 25 minutes, 10 minutes is sufficient. What I'd like to point out here, you're getting an estimation of 93. So this is the same patient. You can combine the two. You can take plasma samples along with the gamma camera method. So as you can see, with the gamma camera method, the GFR comes out to 92.5. With the plasma clearance, it's 93.8. It's very close correlation. So generally, these two will match. So if you want to do it without too much inconvenience, the gamma camera method is fine. For adults, I would not recommend a gamma camera GFR estimation Gates method for children. In an adult, if you want to follow up the same patient over time, the camera method is good enough. In evaluation of hypertension, so renovascular hypertension, it can be a hypertension for renal causes, maybe renovascular, like renal artery stenosis, pheochromocytoma, or renal scarring. Let's see how nuclear medicine investigations help in these. So the gold standard for diagnosis of RAS is renal arteriography with the demonstration of a narrowed renal artery. The problem is it's invasive and costly, and it does not differentiate between hemodynamically significant obstruction that is causing renovascular hypertension from incidental RAS, which is not causing hypertension. That is, it does not establish whether the stenosis is functionally significant or not. This is where captopril renography comes in. So you're all familiar with the mechanism. I'm not going into this detail. There is, because of the RAs, there is increased renin production and angiotensin II production. When you give an ACE inhibitor like captopril, this stops the production, hyperproduction of angiotensin II. So there is a drop in post-glomerular arteriolar pressure. There's a decrease in glomerular filtration pressure, which decreases the function of the affected kidney. This is, if you have a normal renal function to begin with, it is 90% sensitive and specific. As the renal function drops below 30%, you get intermediate results. How is it done? You give an ACE inhibitor and a dose of 0.7 milligram per kg oral dose. This is about approximately an hour before the study. Monitor the blood pressure every 15 minutes after administration. You need to stop ACE inhibitors 5 days prior to the study, and no antihypertensive drugs on the day of the study. One baseline study and one post-captopril study are required. So again, this is how it works. This is the normal state of events. When you have renovascular hypertension, renal artery stenosis causing a stenosis in the afferent arteriole, the angiotensin mechanism kicks in and causes a stenosis in the efferent arteriole to maintain the glomerular filtration pressure. So when you give an ACE inhibitor, it stops the angiotensin 2. There is efferent arteriolar dilatation. The afferent arteriole still remains stenosed because of the pathology. So there is a drop in the renal glomerular filtration. As a result, what happens? The renogram curves, which would have been normal, the affected kidney, there is a slow, steady rise without any subsequent drop in the renogram curve. There are different types of ACE inhibitor effects, as you can see from this curve, which is usually the net result is the curve shifts to the right, there is a drop in the peak, and there is a plateauing of the curve. So you can grade it 1, 2, 3, 4, 5. Unilateral parenchymal retention after ACE inhibition, there is a more than 90% probability. Usually there is a slow gradual accumulation with the retention of the tracer in the affected kidney. So there may be a change in the 20-minute peak to a peak uptake ratio. There's a significantly prolonged transit time, delay in excretion of tracer, and basically a cortical retention with delay in excretion, and the Tmax shifts to the right, the peak, that is. There is also a drop. If there is a drop in function, a more than 10% drop in the relative renal function is definitely indicative of the RAS. So this is one example. Now we hardly ever get any reference for this study nowadays. So I'm just showing you some of my old records. This is a single kidney patient with renovascular hypertension. This is the baseline study. So already you can see that there is a compromise. This is not a normal renogram curve. There is a staggered renogram curve with a delayed peak. But when you do a capillary renography, this is what happens. It just flattens out completely, and there is prolonged cortical retention of the tracer. This is a very, very old study. This is from almost my residency days. That's why it's a different format. So bilateral renovascular disorder. Normally, we wouldn't risk doing this. But here you can see, just concentrate on the renogram curves here. So these are the two renogram curves in the baseline study. Post-captopril, both of them show flattening out. And as you can see from the images, the background significantly increases. There is a sharp drop in the renal function bilaterally. Alternative interventions with enalapril, losartan, and aspirin have also been tried, but these are not very commonly used these days. PET studies have also been tried. You can use O15 water flow study. This is a healthy subject, and this is in renal insufficiency. And when there's renal artery stenosis, as you can see, you can make out the right kidney shows a bright perfusion status with O15 water, whereas the left kidney, which is affected, shows a reduction. This is a research study. It's not routinely done. Now, when you come to the pheochromocytoma diagnosis, so MIBG, I-131 meta-iodobenzyl guanidine. This is meta-iodobenzyl guanidine in a norepinephrine analog. So this is used, it's in the diagnosis of adrenal pheochromocytomas, which may be a cause for hypertension. This is the kind of image you get. It's I-131 labeled. So as a result, the image quality is not very good. But this kind of a focal uptake in the region of the adrenal, in this case, there's a 61-year-old female with hypertension. CECT showed a left adrenal mass. So there is an MIBG-avid mass lesion, which confirms the diagnosis of, and you can combine, this is a SPECT-CT image. So you do a tomographic gamma camera imaging along with superimposed on the CT. You can get a precise location. This is the left adrenal showing high concentration of MIBG. So a left adrenal PO is confirmed. In this case, this is another patient where you have a neuroendocrine tumor. This is a functional neuroendocrine tumor. MIBG can also be used for that. Functional neuroendocrine tumor causing hypertension, confirmed later on surgery. This is a metastatic pheochromocytoma. So multiple metastatic foci, all showing MIBG uptake. Right. Nowadays, we have a better imaging agent as compared to the MIBG. You have this DOTA-NOC or DOTA-TOC or DOTA-TATE. So gallium-68 labeled DOTA peptides are used with PET-CT imaging, which the MIBG imaging has to be done at 48 hours after injection. You have to prepare. There's a lot of preparation involved. It's technically a challenging imaging study, and the image quality is not that good. With gallium dotanol, you get the imaging 1 hour after injection of the tracer, and as you can see, you have SSTR expressing a right adrenal mass out here. So you get much better quality images, big mass with concentration of gallium dotanol. If you have PET-CT facilities available and you have gallium dotanol available, I would recommend going in for that. So renal cortical imaging, finally, DMSA is the tracer used, technetium-99 MDMSA. So as I said earlier, this is cortical binding, and you inject 1 to 5 millicuries. You take static images after about 3 hours, anterior posterior oblique images. And if you have a pinhole collimator, I'll just show you how it helps. You get magnified images. So the applications of these are, you get the relative size, shape, position, and function of the kidney. You can determine cortical scars and pyelonephritis as well as infarcts. Functional cortical mass can be estimated in blunt trauma of the abdomen, like in contact sports or road traffic accidents. You can determine the functional cortical mass following renal trauma. Identification of functional cortical mass in polycystic or multicystic kidneys, and then renal agenesis, ectopia, or congenital anomalies like duplex and horseshoe kidneys. So this is what a normal DMSA scan looks like. These are the planar images and these are the pinhole images. This is an attachment to the gamma camera, which gives you beautiful magnified images with exquisite cortical detail. Now this is a patient where you can see these cortical defects here. The right kidney is okay. The left kidney has this cortical defect at both the poles. So cortical pyelonephritis or scarring. If it reverts back to normal, it was pyelonephritis. If it remains constant for more than a year, then it's likely to be a permanent scar. 6 to 8 months later, same patient, now the left kidney is almost totally gone. The right kidney has also developed the scar at the upper pole. And 18 months after the first scan, you can see the right kidney is also developed bipolar scarring. So you can use it for follow-up. This is a patient most likely with reflux. So high-grade reflux knocking out the left kidney and also causing damage to the right kidney. So successive scans, left kidney, this is the first scan, this is the second scan showing rapid deterioration. Right kidney, first time it was normal, second time upper polar scar, third time bipolar scars. So this is a it is the most sensitive investigation for very early detection of renal pyelonephritis, even more so than ultrasound, because it will detect functional deterioration much before there is a anatomical scar in the kidney that can be detected by ultrasonography. So hydronephrotic kidneys will also cause a problem because now the cortical thickness, there's a thinning of the cortex. So determination of defects becomes difficult. So on the left side, you have a set of hydronephrotic kidneys. On the right side, you have a set of multicystic kidneys. They look pretty much the same on the scan. Multiple renal cysts, again, you will get the same cortical defects. So unless you have a history or an ultrasound correlation, advanced ultrasound says that there's a polycystic kidney or a multiple cysts in the kidney, these will look just like scars. So these scans have to be very carefully correlated with the clinical history. Patient with blunt trauma abdomen. This is one patient where the left kidney shows a normal functional renal mass, right kidney damage to the cortex. This is yet another patient followed up over time. So first time the left kidney, you should see this transection. Second time there is some recovery of the functional cortical mass in the mid-cortical region. Now role of FDG PET. Sometimes we do use it in infection of renal cysts. So this is a patient where you have a non-infected renal cyst on the right side. You can see it in the coronal images as well as in the transaxial images. Cold area, there's no uptake of tracer here in the cyst. Whereas in an infected polycystic kidney, this is a polycystic kidney disease with cyst infection, FDG PET-CT has been done. Very high avidity of FDG in the cysts. So these are infected cysts. FDG PET can also be used in primary RCC to detect lymph node, lung, and brain metastasis. So all these multiple foci in the different regions disease. Now, evaluation of vesicuratory reflux, this can be done either indirectly or directly. So talking about both, indirect radionuclide cystourography or IRCG is usually done as a dynamic study following a DTP or an EC scan. Provided there is no obstruction, You wait till the kidneys have cleared out, all the tracer is collected in the bladder, and then you ask the patient to void while standing in front of the gamma camera. So any tracer going up into the ureter would indicate a reflux. This is non-invasive, but it is less sensitive because sometimes there is activity left over in the ureter. You'll be left wondering, is it tracer coming down the ureter or is it tracer going up the ureter? To avoid this problem, we have what is called as a DRCG, where tracer is injected by direct suprapubic injection into the full bladder. Now, this becomes slightly invasive, but it is a very, very sensitive investigation. This is how it's done. You ask the patient to drink water till the bladder is full. You palpate. Those who are very thin can do an ultrasound examination to check whether the bladder is full, but usually it's not very difficult, especially in young children where the bladder, the abdominal wall is not very fat. So once you've palpated, you take a routine ordinary syringe with a 1.5-inch needle, ordinary hypodermic needle, usually of a 22 or a 21 gauge. You take the radiotracer, that's a non-absorbable, something like technetium sulfur colloid, approximately 1 millicurie only. So you just puncture the bladder through the anterior abdominal wall, withdraw, see that there is urine coming into the syringe, and then you inject it back into the full bladder, after which you position the patient in front of the gamma camera, back to the camera, and ask them to void into a container. So this is how a DRCG study looks like. Since there is activity only in the bladder, any activity going up from the bladder is a reflux. So this is again in the posterior projection. So you see a left-sided vesicular reflux. This is in the voiding phase. This is immediate pre-void. So there is a reflux in the pre-void image itself. This is the post-void image after the child has finished voiding. So no reflux on the right side, high-grade vesicular reflux on the left side. This is a patient with a bilateral vesicular reflux on a DRCG, pre-void and post-void images on the voiding phase. Another use for the dynamic renal scintigraphy. Now, this is a rare case. Somebody attempted a PCN and resulted in a urinothorax. So we did a routine technetium EC dynamic renal scintigraphy. So as you can see, during the study, there is a photopenic defect in the region of the lung. This patient reported with a so-called pleural effusion on the chest X-ray. There was fluid in the right lung. So as you can see, during the study, there is a collection of the tracer going out of the right kidney into superior to the right kidney, and then it starts collecting. This is in the pleural cavity. Delayed images also. So there is excretion from the through the ureter as well, pleural cavity. So this is a right-sided urinothorax. This is what happens when the creatinine is very high. You will not get any renal anatomy. All you will get is a high background activity. So it's a bilaterally poorly functioning kidney. So depending on what the creatinine is and what is the tracer that you're using, please don't attempt this scan if it is beyond the range. As I said, DTPA, maximum creatinine of 2 milligram per deciliter. With the technetium EC, you can go up to 3.5, but not more than that. After that, all you'll get is a high background activity like this. Now, this is what happens when you give iodinated contrast. So this is a DMSA scan 1 day after an iodinated contrast study was done, mainly high background activity with poor renal differentiation. Wait for 7 days and we do a DTPA scan and 2 beautifully delineated kidneys with a beautiful renogram curve. Kidney. Now, this is again on a DMSA scan. This is the IVP in the anterior projection. This is the DMSA scan, anterior and posterior projection. So you can make out faint uptake on the left side. This is a hydronephrotic left moiety of the horseshoe kidney. You can also make out the functioning isthmus. So DMSA scans are very useful when it comes to evaluation of the function of the isthmus and any hydronephrotic moiety here. You can get a variety of horseshoe kidneys. These are the different shapes that we have seen on some DMSA scans. You can also use the DMSA scan to identify ectopic low-lying kidneys, different positions of the kidneys, and variation in the kidney shapes using DMSA, fused ectopic kidneys, pancake kidneys, J-shaped or L-shaped back-to-back kidneys, a whole variety. So how much of it is functional and where they may be located low down in the bladder, ectopic in the abdomen, wherever they may be. Coming to renal transplant evaluation. So you can use the dynamic renal scintigraphy to detect perfusion, function, and drainage of the transplant kidney, detect acute transplant rejection, ATN, urine leaks, and peri-transplant collections. So this is a renal transplant normally functioning. excellent perfusion. You can see the kidney within 2 seconds after appearance of the iliac vessels. Excellent cortical function, bladder appearing within 4 to 5 minutes, a good renogram curve. In a transplant kidney, usually this is the best curve that you will get. It won't be as sharp as the normal position kidney curves, but draining out completely into the bladder by the end of the study. So normal transplant function, right? Acute transplant rejection. Now out here you can say we hardly ever get any of these studies anymore, so I have to withdraw this from the medical literature. So out here you can see the kidney is taking a very long time to appear after appearance of the iliac vessels. So delayed perfusion, high background activity, poor cortical function. The delayed perfusion is a hallmark of transplant rejection. Whereas in acute tubular necrosis, the perfusion is maintained. You can see within 2 seconds of the appearance of these are 2-second images. So appearance of the iliac vessel, immediately after that there is appearance of the transplant. Perfusion maintained, background raise, function is a little depressed. This is ATN as compared to acute rejection where the perfusion and function are both suppressed. This is a completely non-viable graft. There is no uptake whatsoever in the transplant kidney. This is a totally gone case kidney. It's a non-viable renal graft. Also seen, you will get a similar type of picture in arterial or venous thrombosis of the transplant kidney. There is no kidney, there is no entry of the tracer at all into the graft. Now, there are certain quantitative parameters that are used, like Hilson's perfusion index. So, what we do is we mark an ROI and you see the aortic perfusion curve and the renal perfusion curve. So in case of a rejection, the renal curve will go down. So the aorta divided by the kidney, this ratio will rise much, much higher. Usually in a normal kidney, the two curves should almost coincide. So they'll be roughly equal. Post-transplant perinaphric fluid collection. Now, this is where it helps in differentiating urinoma from non-urinomas. So these will include lymphocele, hematoma, and abscess. They will all look the same on the scan. The urinoma will show a collection of tracer in the adjacent to the kidney. A persistent photopenic defect would indicate one of these three: hematoma, lymphocele, or abscess, which has to be then correlated with the clinical condition of the patient. In a urine extravasation, an initially photopenic area will become hotter over time, like this. So initial transplant kidney, good perfusion, good function, and then you see this photopenic area in the region adjacent. There's a halo-like thing, which over time fills up with tracer. So this is a urine leak communicating with the collection adjacent to the kidney. If you have SPECT-CT capabilities, they will show you elegantly the collection along with the anatomical delineation. A lymphocele, on the other hand, this is a lymphocele. It's a cold area which remains persistently cold, and it's only up to 24 hours that you will see some faint gathering of tracer in this region. A urinoma will show very quick extravasation within an hour or two in this collection. Patients on peritoneal dialysis sometimes have this problem. There is a peritoneo-scrotal communication because of an open processus vaginalis. When you're giving the dialysis fluid, there is excessive collection of traces. So it's a very simple investigation. All you have to do is inject 2 to 3 millicuries or up to 5 millicuries of technetium sulfur colloid through the dialysis port along with the dialysis fluid, and just take serial static images. So if there is a communication, then you will see this communication into the scrotal sac. It can be unilateral or bilateral, and it might sometimes go up into the thorax also for a peritoneal-pleural communication. So that's about it. There's a whole lot of investigations you can do. I'll be happy to take any questions, any doubts that you have. Most welcome. So any questions, please, you can either ask or put it in the chat box. I'm looking at the chat box right now. Thank you, Dr. Shashank. If you have any queries, I'll be glad to take them. One thing I would like to emphasize, we often get queries from our clinical colleagues about the renogram curve. Please give us the renogram curve. Can we see the renogram curve? We don't report directly on the renogram curve. So it is the images that we report on, and the renogram curve is an indirect representation of what we're actually looking at in the images. Okay, question here. How to check split function of the kidneys if low grade GFR like less than 25 ml per minute? Difficult situation. I would suggest using a tubular agent like technetium EC. And if you can see, one advantage with this investigation is if you can see the kidney, we can get a split function. Okay, but you need to see the kidneys. If the background is so high that the kidney cannot be seen, or if it's a small kidney, or one kidney is, this is relative function. Total being 100, so it's a 50-50 split, or one side may be poorly functioning, in which case it goes up to 75-25 or 80-20 or 90-10 or whatever. If the total GFR itself is below 25 ml per minute, then you are not really going to see very much of kidney. So it depends. If you can get some kind of a renal visualization, if you're capable, you have to be able to draw a region of interest. If you cannot get sufficient visualization of the kidney that you can't even draw an ROI over the kidney, then you will not get a split function. Then all we can say is bilaterally poorly functioning kidneys and leave it at that. Yes, very much. Max can help. As I said, the GFR is low. The tubular agents like MAG3 or LLEC both can help. They have a much higher extraction fraction. So maybe when you're not seeing the kidney on a DTPA scan, you might still see a kidney on the MAG3 scan or the LLEC scan. Well, thank you for listening. Any other queries? Please feel free to ask. I mean, there's no such thing as a bad question or a stupid question. I think any question is welcome. Okay, sometimes for renal donor evaluation, GFR comes out as 80, but differential of each would not total 80. Why is that so? No, if the GFR is 80, then the split GFR has to total 80, because we are not individually evaluating the GFR of each kidney. The GFR is of the total combined effort of both the kidneys. The split function is based on the region of interest being placed on the kidney, which only gives a percentage contribution of each kidney. That percentage contribution is then extrapolated onto the total GFR. So even if you look at the results column, the values that you get for individual GFR are actually a function of the split function. It may be off by maybe 0.1 or 0.2. That's a computer error, mathematical error, whatever you call it. But the way we go about it is the total GFR, whatever it comes out, 80, 70, 100, whatever it is, the percentage function that is given along with it. So if it is 40% and 60% for the left and the right kidney, then the left kidney would be 40% of 80 and the right kidney would be 60% of 80. Best investigation to ascertain urinoma. Technetium LLEC. Or if you don't have EC, MAG3, equally good. But in India, most people use LLEC. The reason I'm saying EC and not DTP is there's a very fast clearance. The drainage is quick. You're not expecting any kind of renal obstruction out here. If you don't have EC or MAG3, you can still use DTPA. There's nothing against using DTPA. But since you asked what is the best investigation, I would recommend technetium LLEC or technetium MAG3. Is it possible that for normalization of GFR as per body area to underestimate GFR in Indian population or those with lower? Yes, very much, very much. Because these algorithms have been prepared for the Western population. So ideally, we should work out our own algorithms for our indigenous population, body weight and height. So there may be a slight under or occasionally overestimation when you use the same formula. Correction for body surface area to be used for all agents. Yes. If you're talking GFR, then we're only talking DTPA, because EC and MAG3 will not be used for evaluating GFR. But correction for body surface area should be used, especially when, if you have somebody around the average 70 kg adult, 65 to 75 kg, this doesn't make very much of a difference. But occasionally you have a grossly undernourished patient, or a grossly obese patient, or say you're following up the patient during a chemotherapy regimen where the patient is going to lose weight or has lost weight in the course of treatment, or the other way around, patient has gained weight. So that is where it becomes vitally important.
I think so. There are no more questions.
Okay.
Thank you so much for the session, sir.
Most
and with
welcome.
your permission, sir, can we share the recording of today's session with the students?
Yeah, sure. There are only around 18 or 19 students there were that I could see. So if somebody has missed out, then they're
Yes,
welcome.
sir.
And if there are any other questions, then they can always email. You have my email ID, so
Right, sir.
no problem with this. There's one more question. Somebody's just popped up.
Oh, yes, sir.
As I said, technetium EC is not done above create 3.5. Then how to find out differential function for a poorly functioning kidney for planning nephrectomy? Okay. Now here is a real problem. If you have a create above 3.5, now it means that both the kidneys are really poorly functioning. So nephrectomy would, you want to remove one of the two poorly functioning kidneys and you want to see the worst one. You can still do an EC and see. As I said, if you can see some kidney, you will still get maybe some kind of a differential function. But at a certain point of time, sometimes you get a patient on dialysis with a create of 7 or 8. You're not going to get any kind of kidney visualization out there. So in such cases, there is really nothing much we can do. If it's one of the kidneys which is more poorly functioning, then just do the scan and see if you can see one kidney, you don't see the other kidney, then the non-visualized kidney is the worst one. Shouldn't nephrectomy be based on symptoms? I don't take decisions on nephrectomy, sorry. If you have a query about the functionality of the kidneys, we can help out as much as possible. But if it's a surgical decision as to know whether nephrectomy should be done or which one should be done, we can guide you as to which kidney is functioning better or which kidney is functioning poorly. But decision for nephrectomy is entirely up to the nephrologist and the surgeon. If it's a bilaterally poorly functioning, if you expect, You're expecting some improvement depending on the original etiology, the pathogenesis of why were the kidneys poorly functioning in the first place. If you can reverse the course of the disease, a whole lot of other factors. So we can only tell you whether which kidney is better functioning or worse functioning, and if there is any obstructive element. Obstructive element, of course, depending on how good the function is. Unless the kidney is functioning, we won't be able to comment on drainage either. So those are our limitations. Beyond a creat of 3.5 or 4, nothing really that we can. Okay, thank you. Can we wind up? I don't think there are any other questions coming in. As I said, anything else, I'll be glad to take questions in another session some other day, or you can email them into me.
Sure, sir. Thank you so much.
Thank you. Most welcome.
Thank you, sir. Thank you for sparing your time, sir.
Okay. I'm logging.